there's still data that suggests that patients who have metastatic hormone-sensitive prostate cancer, they're up to 50% of patients are still getting under treatment with just single agent ADT. What is your practice of adding NHT agents, docetaxel? Do you use doublets? Do you use triplets? How do you think about approaching patients with initial metastatic hormone-sensitive disease?
I can take that. So, for any individual with hormone-sensitive metastatic prostate cancer, I'm always thinking a doublet therapy first, unless I think they do have higher risk disease, then I have a bias towards adding docetaxel, the docetaxel darolutamide, with the androgen deprivation therapy, or if I think they have adequate performance status. So I'll look at age, performance status. Do I think they have a higher aggressive disease, visceral metastasis greater than 4, bone metastasis? And the majority of patients will, I'm going to recommend a doublet or a triplet therapy unless their performance status is very poor, and then I may only use androgen deprivation therapy, single agent.
Yeah, I was thinking through that. I agree, probably one of those in those 50%, because that's a big number, and it's not like, we can sit here and discuss as long as we can always say I use triplet or doublet too as well, but I've used single agent as well. I agree with Dr. Sherrington that there are other factors, especially where I'm in East Mesa, where the population is much, much older. Really, they don't want to deal with a lot of side effects, and they really prefer quality of life, and especially low volume disease, 80-some-year-old. I do have a discussion saying adding a second agent really doesn't add a lot more toxicity, but they're still very apprehensive. They want to start with single agent, and so I probably would be in those cusp of, but where possible, young and better performance status, I typically tend to start doublet. And if it's a very high volume disease with liver disease, I do also consider systemic chemotherapy.
Mine's predominantly a doublet or triplet therapy for the majority of patients if they're of good performance status and kind of what their expected survival is from other comorbidities. I think the era of single agent ADT is past in a lot of ways. And also thinking about kind of triple therapy versus quad therapy. Are we including bone strengthening medications and those sorts of things, which can really reduce some of the risks of metastatic prostate cancer.
Thank you. Yeah, I think you raised some very interesting points in relation to real-world practice.
Right.
I think in that context, ARANOTE data is really interesting. It shows that when darolutamide was added to ADT, there was no real increase in side effects. And,
absolutely, I agree with that.
There was very little increase in fatigue. Actually, patients on the darolutamide had fewer side effects.
Right.
So I think as we move forward into this doublets and triplets era, I think most patients, I think all we agree that should be getting at least doublet treatment with ADT plus NHT, and then thinking about where we should add docetaxel chemotherapy.
Of course.
And the way I thought about these patients is, and I would like to hear your thoughts, is if somebody presents with high volume disease on conventional scan and synchronous presentation, I think about triplet therapy. If the patient has a metastatic presentation where the patient had localized disease before, got definitive treatment, now recurring with low volume disease, I think ADT plus NHT doublet is a standard of care. In between patients, could be the doublets or triplets. I really don't use much of the docetaxel doublet, ADT plus dosi in the CSPC setting, or single agent, unless there is a very compelling reason for a single agent ADT.
Yeah, I agree, and that's what I think we all concurred, right? So, docetaxel is an addition to the therapy we have, a doublet we have.
Yeah, absolutely. I think this is fantastic.